everyone and welcome back. So revise thyroid topic with me. So thyroid is supplied by, this is the very important and favorite questions of the examiners, that what is the supply of the thyroid. So thyroid is supplied by superior thyroid artery, inferior thyroid artery and thyroid artery. Superior thyroid artery arises from external carotid artery, inferior thyroid artery arises from thyrocervical artery, and thyroid artery arises from brachiocephalic trunk. Okay, brachiocephalic trunk. Thyrocervical artery, external carotid artery. So these are the three arteries: thyroid, superior thyroid artery, inferior thyroid artery, and thyroid artery. The superior thyroid artery arises from the carotid artery, external carotid artery, and the inferior thyroid artery arises from the thyrocervical artery, thyrocervical artery, and the thyroid artery arises from the brachiocephalic trunk. Okay, external carotid artery, then thyrocervical artery, and then brachiocephalic. External carotid, thyrocervical, and brachiocephalic. Okay. Now the synthesis of thyroid hormone. So it is done by trapping, then oxidation, then binding, then coupling, and then secretions. These are the 4 steps, 5 steps. Okay. How the synthesis of thyroid occur? First of all, trapping is occur, then oxidation, then binding, then coupling, and then secretion. Trapping, oxidation, binding, coupling, and secretion. Trapping, oxidation, binding, coupling, and secretion. These are the steps of synthesis of hormone. So these are the favorite viva questions, that what is the supply of the thyroid. So thyroid is supplied by thyroid superior artery, which arises from the external carotid, then the thyroid superior inferior artery, which arises from the thyrocervical artery, and the thyroid artery, which arises from the brachiocephalic trunk. Then in the examiner may ask that what are the steps of thyroid synthesis. So these are trapping, oxidation, binding, coupling, and secretion. Okay, trapping, oxidation, binding, coupling, and secretion. These are the 5 steps of the synthesis of thyroid. Now what are the investigations for the thyroid diseases? So these are, first of all, thyroid stimulating hormone level is checked, that is the normal level is 0.3 to 3.3 micro, and TSH is decreased as a thyrotoxicity, and TSH is increasing hypothyroidism. Okay, so these are the investigations of for thyroid diseases. First of all, the thyroid stimulating hormone is checked. So the thyroid stimulating hormone normal level is 0.3 to 3.3. If TSH increase, that is thyroid stimulating hormone decrease, then it is thyrotoxicosis, and if thyroid stimulating hormone increase, then it is hypothyroidism. Okay, TSH decrease, thyrotoxicosis; TSH increase, then hypothyroidism. Then we will do the T3 and T4 level check. It provides the information about the functional status of the thyroid. T3 and T4 show us that whether the thyroid is functional or not. So euthyroid is normal functioning, that is T3, T4, and TSH with normal. And thyrotoxicosis is decreased thyroid stimulating hormone and increased T3 and T4. And in hypothyroidism, increased TSH and decreased T3 and T4. T3 toxicity, decreased normal TSH, and increased T3 and T4. Okay. So first of all, we have checked the thyroid stimulating hormone, which is TSH. Then we have checked the T3 and T4 levels. This provides the functional status of the thyroid. So in euthyroid is normal functioning thyroid. In it, the T2, T3, T4, and TSH are normal. Then we are having the thyrotoxicosis. In thyrotoxicosis, TSH is decreased and T3 and T4 is raised. Then in hypothyroidism, the TSH is decreased and the T3 and T4 are the TSH is raised and T4 and T3 are decreased. In the T3 toxicity, TSH is decreased and T3 and T3 is raised only. Okay, so these are the thyroid tests. First of all, we have done the TSH stimulating test, and in it, if the TSH is raised, that is increased, then T3 and T4 are decreased, and this is hypothyroidism. And if its TSH is decreased, then this is thyrotoxicosis. Okay, then T3 and T4 levels. So if these T3 and T4 are normal, then it is euthyroid. If T3 and T4 are raised, then it is thyrotoxicosis. And if T3 and T4 are decreased, then it is hypothyroidism. And if only T3 is increased, then this is T3 toxicity. Okay, now coming towards the thyroid autoantibodies. The thyroid autoantibodies are checked, that is anti-thyroid peroxidase and anti-thyroglobulin and thyroid receptor antibodies. Okay, anti-thyroid peroxidase, anti-thyroglobulin and thyroid receptor antibodies. Thyroid receptor antibodies and anti-thyroglobulins and anti-thyroid peroxidase. Okay, thyroid antibodies, anti-thyroid peroxidase, anti-thyroglobulin and thyroid receptor antibodies. Ultrasound scan is done which differentiate the solid mass from cystic one, and CT scan is done which is in case of suspected malignancy, and stop scanning is done of thyroid, and final aspiration in case of a discrete or solitary thyroid swelling, and X-ray chest and thoracic inlet is done. So these are the basic investigations which are done in the case of thyroid diseases. These are TSH test, T3 and T4 test, ultrasound scan, CT scan, MRI, MRI not, isotope scanning, and final aspiration, X-ray chest and thoracic inlet. So these are the specific investigations. Okay. Okay, now what is thyroglossal cyst? We should remember this, okay, that what is euthyroid, what is thyrotoxicosis, what is hypothyroidism, and what is the T3 toxicity, and what are the investigations that are done for the thyroid. These are thyroid autoantibodies, which is anti-thyroid peroxidase, anti-thyroglobulins, and thyroid receptor antibodies. This is ultrasound scan, which is differentiate the solid mass, and this is the CT scan, which is done in case of suspected malignancy, and this is isotope scanning, and this is fine needle aspiration, which is done in case of discrete solitary thyroid swelling, and this is X-ray chest. Now thyroglossal cyst. Thyroglossal cyst is irregular neck mass or lump which develop from cells or tissues left over after formation of thyroid gland during developmental stages. Okay, what is thyroglossal cyst? It is irregular neck mass. Thyroglossal cyst is irregular neck mass or a lump which develop from cells or tissues left over after the formation of thyroid gland during developmental stages. Thyroglossal cyst is irregular neck mass or lump which develop from the cells or tissues left over after formation of thyroid gland. And it is located below the hyoid bone. Okay, thyroglossal cyst is located below the hyoid bone. Occur anywhere along the path of the thyroglossal duct from base of the tongue to the suprasternal notch. Okay, it can occur in any place occur anywhere along the path of the thyroglossal duct from the base of the tongue to the suprasternal notch. Now the clinical features. Thyroglossal cyst. Okay. Thyroglossal cyst. This is thyroglossal cyst. So here in this paragraph it is described that it is irregular neck mass or lump developed from cells or tissues left over, and it is located below the hyoid bone. This is hyoid bone, and the thyroglossal duct is located below this hyoid bone, and it occurs anywhere along the path of the thyroglossal duct. This is the path of the thyroglossal duct. Okay, This is thyroglottal duct, and the cyst that occur here is a thyroglossal cyst, and it is formed from the leftover of when the thyroid gland is formed. Okay, so this is thyroglossal cyst. Now, what are the clinical features? Clinical features are that midline swelling is present and it moves upward with swallowing as well as protrusion of the tongue. As it is present in the thyroglossal duct system. Okay, so when you protrude your tongue, it will moves up. When you swallow, it will moves up. Okay, unlike thyroid, which moves only with swelling, thyroid only moves with swelling, while the thyroglossal duct also moves with protrusion tongue. So this way you can differentiate between the thyroglossal cyst and the thyroid gland. The treatment options for thyroglossal cyst is cyst trunk operation, which is the removal of whole of thyroglossal tract, which involves the removal of the body of hyoid bone up to the base of the trunk. Okay, if the cyst occur, as we have studied that the above is hyoid bone, and here is the cyst, and here is the thyroglossal duct. So if the cyst occur here, then you have to remove this. You have to remove this hyoid bone, then this thyroglossal cyst, and this duct, and this procedure is known as cyst trunk operation. Okay, so we have studied thyroglossal cyst. It is irregular neck mass or lump which develop from cells or tissues left over or the formation of thyroid gland. And the clinical features are midline swelling, which moves upward with swelling as well as protrusion of the tongue, and it is unlike thyroid, which moves only with swelling. The treatment options are cyst trunk operation, removal of whole thyroglossal tract. Now coming towards the next topic, that is goiter or thyrotoxicosis. So we are having a scenario for goiter or thyrotoxicosis, as we have studied that if the TSH is raised, then it will lead to thyrotoxicosis. So in goiter the TSH is raised. So we are having a scenario that there is a 50-year-old multinodular goiter and swelling in the neck, and she has lost 8 kg, and she is having loose motion. On examination, she is thin and having tremors, and heart rate is 110, and neck is smooth, moderate enlargement is present. Okay, if TSH is raised, it means that T3 and T4 is decreased. So this is hypothyroidism. Okay, and these are the signs of hypothyroidism. Goiter occur in hypothyroidism, and these are the clinical features. That is the tremors, the increased heart rate, and the thin and febrile, and neck smooth, moderate enlargement, and weight loss. Okay, so the causes or classification of the goiter is that it is simple goiter, it is euthyroid, and it is diffuse or multinodular. Then we are having toxic goiter, which is hyperthyroidism, which may be diffuse, multinodular, or toxic adenoma. Then we are having hypothyroidism, which is usually multinodular. Then neoplastic, which is benign and malignant. And then inflammatory, which is autoimmune, that is Hashimoto's disease. Granulomatous, which is bacterial and viral, and fibrosing, that is Riedl's thyroiditis. So these are the classification of goiter. We are having simple goiter, which is euthyroid, toxic goiter, which is hyperthyroidism and hypothyroidism, neoplastic goiter, hypothyroidism goiter, and inflammatory goiter. In inflammatory goiter, we are having autoimmune, granulomatous, bacterial, and fibrosing, that is Riedl's thyroiditis. And hypothyroidism is usually multinodular, and these are the classes and classification. Okay, goiter, thyrotoxicosis. So in this scenario, it is mentioned that there is multinodular goiter and swelling in the neck, and loss of 8 kg, and bowel loose motion, and thin and tremors, and increased heart rate, and neck is smooth, moderate, and enlarged. So these are the classes, that is simple goiter, which is euthyroid, diffuse or multinodular, then toxic, which is hyperthyroidism, diffuse, multinodular, or toxic, and then hypothyroidism, which is usually multinodular, and neoplastic, which is benign or malignant, and then inflammatory, in which we are having the autoimmune, Hashimoto's disease, granulomatous, that is thyroiditis, bacterial or viral, fibrosing, which is Riedl's thyroiditis. So this was about the goiter or thyrotoxicosis. Now next topic is hyperthyroidism or thyrotoxicosis. Okay, so hyperthyroidism. Hyperthyroidism is the overproduction of T3 and T4, and because of the feedback mechanism, serum TSH levels are reduced. In the it will be like this. The pattern will be TSH will be increased, T3 will be increased, and T4 will be increased. As a result of decreased TSH, which is thyroid stimulating hormone, there will be excessive thyroid hormones. Okay, now the common causes of hyperthyroidism and the rare causes. The common causes are diffuse toxic, that is goiter 70% Graves' disease, and toxic multinodular goiter and toxic nodule, that is adenoma. These are the causes of hyperthyroidism. The rare causes are thyrotoxicosis fasciata, job-based dose thyrotoxicosis, acute form of thyroiditis, secondary carcinoma, and neonatal thyrotoxicosis. These are the rare causes. Overproduction of the T3 and T4, and because of the feedback mechanism, serum TSH levels are reduced. There is excessive thyroid hormone, and these are the common causes. First of all, the diffuse toxic goiter, which is Graves' disease, and a toxic multinodular goiter, and then the toxic nodule, that is adenoma. These are the causes. Okay, adenoma. Diffuse toxic Graves' disease and multinodular goiter, and then nodules, that is adenoma, toxic nodules, that is adenoma. Okay, these are the common causes. The rare causes are thyrotoxicosis fasciatia, then job-based thyrotoxicosis, then acute form of thyroiditis, then secondary carcinoma, and then neonatal thyrotoxicosis. Neonatal thyrotoxicosis and secondary carcinoma, acute form of thyroiditis, and job-based thyrotoxicosis and thyrotoxicosis fasciata. The Graves' disease. Thyroid, page number 92. Okay, so we were here. These are the common causes. Where is my pencil? These are the rare causes, that is thyrotoxicosis fasciitis, job-based thyrotoxicosis, acute form of thyroiditis, secondary carcinoma, and neonatal thyrotoxicosis. Okay, now what is Graves' disease? Graves' disease is diffuse toxic goiter. We have discussed goiter, the classification of goiter. Now we will discuss the Graves' disease, which is diffuse toxic goiter. Okay, so the common causes are diffuse toxic Graves' disease and toxic multinodular goiter and the toxic nodule or adenoma. And the rare causes are thyrotoxicosis fasciatia, job-based thyrotoxicosis, acute form of thyroiditis, secondary carcinoma, and neonatal thyrotoxicosis. Now coming towards the Graves' disease. So Graves' disease is the most common cause of thyrotoxicosis, more than 70% cases. Okay, Graves' disease and goiter all are these because of the increased thyroid stimulating hormone. Because of the vitamin C and TSH levels are okay. So in the Graves' disease, the TSH is less and the T3 and T4 levels are high. So Graves' disease is the most common cause of thyrotoxicosis, more than 70% cases, and the disease is autoimmune in nature and is caused by abnormal production of the thyroid stimulating antibody. Disease is autoimmune in nature and it is caused by the abnormal production of thyroid stimulating antibody. There are increased level of T3 and T4, which leads to the thyrotoxicosis. Simultaneous appearance of the goiter and is called primary thyrotoxicosis. Eye signs are more pronounced in it. Graves' ophthalmology. Treatment: above 45 years radioactive iodine, below 45 years surgery is required. So this is Graves' disease. What occurs that in Graves' disease, it is the most common cause of thyrotoxicosis, which is more than 70% cases. And disease is autoimmune in nature and is caused by abnormal production of thyroid stimulating hormone. And there are increased level of T3 and T4, thus leading to thyrotoxicosis and simultaneous appearance of the goiter, and is called primary thyrotoxicosis. The treatment options are for above 45 years of age, radioactive iodine is given, and for below 45 years of age, surgery is done. concept of Graves' disease or goiter. This is an autoimmune disease, in which very high amount of the thyroid hormone is generated, which leads to enlarged goiter. Thyroid hormone, enlarged goiter. So this is the basic concept. So if it occurs above the 45 years of age, then radioactive iodine is given. And if it occurs below the age of 45 years, then surgery is done. Now, toxic multinodular goiter. It occurs in older individuals with prior history of non-toxic multinodular goiter. First of all, when goiter occurs, it is non-toxic. With time, it develops towards a toxic. So the toxic multinodular goiter occurs in older individuals with prior history of non-toxic multinodular goiter. Rare eye problems, common cardiac problems. Syndrome is called secondary thyrotoxicosis. In toxic and toxic multinodular goiter, rare eye problems are present and common cardiac problems are present. And the syndrome is called secondary thyrotoxicosis. The clinical features of toxic multinodular goiters are palpitations, that is heat intolerance, and weight loss in spite of good appetite, increased appetite, insomnia, restlessness, diarrhea, and menstrual irregularities. This is a kind of hyperthyroidism. So palpitations are present. There is overproduction of thyroid hormone, hyperthyroidism. So palpitations, heat intolerance, weight loss in spite of good appetite, increased appetite, insomnia, restlessness, diarrhea, and menstrual irregularities. These are present in the case of toxic multinodular goiter. These are the symptoms. The signs are tachycardia, exophthalmos, exaggerated reflexes, pretibial myxedema, fine ring resting tremors, thyroid ectopathy, hot moist palm, little leg retraction, thyroid bruising, and cardiac arrhythmias. These are the signs. Okay, so these signs and symptoms are important for the examinations, especially in case of hyperthyroidism. Tremors are present, and palpitations, tachycardia is present, and there will be exophthalmos, and there will be exaggerated reflexes, and there will be pretibial myxedema, and there will be cardiac arrhythmias and fine resting tremors, and there will be tachycardia, and there will be thyroid ectopathy and hot moist palm and leg retraction. These are the symptoms. Okay, so you should remember these points, that the toxic multinodular goiter occurs in older individuals with prior history of non-toxic multinodular goiter, and rare eye problems and common cardiac problems are present along with it, and the syndrome is called secondary thyrotoxicosis. These are the clinical features, that is palpitations, heat intolerance, weight loss, and increased appetite, insomnia, restlessness, diarrhea, and menstrual irregularities. And these are the signs: thyroid ectopathy, tachycardia, hot moist palm, exophthalmos, lid or leg retraction, exaggerated reflexes, thyroid bruit, pretibial myxedema, cardiac arrhythmias, and fine resting tremors. Now these are the investigations options that are done in case of the toxic multinodular goiter or Graves' disease. These are: there will be increased T3 and T4, and there will be reduced TSH. Thyroid scan is only indicated in case of nodularity and toxicity. It is useful to look at the functionally active nodules. Thyroid scan is done to find if there is any nodules present and if there is any toxicity, and it is useful to look at the functionally active nodules. Now the treatment options are that for thyroid, medications are given which are anti-thyroid drugs, and radioablation is done, and surgery is done. The patient prep for surgery. Okay, so carbimazole and iodides and beta blockers pre-op investigations is performed, and fluid and electrolytes are corrected. Antibiotic prophylaxis is done. This is the patient prep for surgery, and after this preparation, the patient is gone under surgery. The complications are anesthesia complications and uncontrolled bleeding, nerve injury, cardiac injury, and thyroid crisis. Okay, so toxic multinodular goiter, and these are the clinical features, these are the signs, these are the investigations, these are the treatment options, which are anti-thyroid drug, and radioablation and surgery. Carbimazole hydrates beta blockers. Pre-op investigations performed. Fluid electrolyte is correct. Antibiotic prophylaxis. And these are complications. So these are the specific treatment options for multinodular goiter. These are surgery and radioactive iodine and antithyroid drugs. These are the options. So in surgery, radioactive iodine is given orally, taken by thyroid follicle, and we are having both advantages and disadvantages of this method. The advantages are that it is cure rapid. This is surgery. Okay, here I have written it wrong. This is surgery and this is radioactive iodine. Okay. So radioactive iodine is given, and radioactive iodine is given orally, and it is taken by thyroid follicles. The advantages are that with radioactive iodine the cure is rapid, and the disadvantages is that there is risk of hypothyroidism and the recurrence of laryngeal nerve injury and the recurrence of thyrotoxicosis in case of subtotal thyroidectomy. Now in case of surgery, in toxic and nodular goiter surgery, subtotal or total thyroidectomy is done. The advantages and disadvantages are present. In advantages, here is a mistake. These advantages and disadvantages are of radioactive iodine, and these advantages and disadvantages are of surgery. And this is the definition for radioactive iodine, and this is the definition for surgery. Okay, so the radioactive iodine advantages are that no surgery is required and there will be no prolonged drug treatment, and the disadvantages are that late hypothyroidism may occur. The advantages of surgery are that it is cure rapid, and the risk of hypothyroidism is here, and recurrence of laryngeal nerve injury can occur, and recurrent of thyrotoxicosis in case of subtotal thyroidectomy can occur. Antithyroid drugs are used, which are carbimazole and propylthiouracil, and propranolol, which is for cardiovascular effects, and carbimazole is given, and euthyroid 5 mg TDS for 6 to 24 months. The advantages is that there is no surgery and no use of radioactive iodine, and the disadvantages is that it is a prolonged treatment, 6 to 24 months, and failure rate is 50%. Aplastic anemia may occur, and oropharyngeal bacterial infections can occur due to antithyroid drugs. So the most important thing here that you should remember is that which one are the antithyroid drugs. So these are carbimazole and propylthiouracil and beta blockers, which are used for cardiovascular effects. Okay, so let me revise. Okay, problems in the treatment of thyrotoxicosis. So in pregnancy, radioactive iodine is contraindicated, and thyrocardic are radioiodine plus antithyroid drugs, and proptosis antithyroid drugs. Recurrence antithyroid drugs plus radioactive iodine. Further surgeons causes a lot of complications. If you are treating thyrotoxicosis, then what are the points that you should be taking care of? In pregnancy, radioactive iodine is contraindicated. In thyrocardiac issues, radioactive iodine plus antithyroid drugs are given. In case of proptosis, antithyroid drugs are given, and if recurrence occurs, then antithyroid drugs plus radioactive iodine, and further surgeries causes loss of complication. So this was about the toxic multinodular goiter or Graves' disease, and occurs in the older individual with priority history of non-toxic multinodular goiter, and there is rare eye problems and common cardiac problems. These are the symptoms, that is palpitations, heat intolerance, weight loss, increased appetite, insomnia, restlessness, diarrhea, and menstrual irregularities. And these are the signs, that is tachycardia, exophthalmos, leg retraction, exaggerated reflexes, thyroid bruising. The investigations are decreased T3 and T4 and decreased TSH, and the treatment options are medications and radioablations and surgery. And this is the prep for surgery, which are carbimazole, iodides, beta blockers, pre-op investigations, fluid electrolytes, and antibiotics. The complications are of anesthesia and uncontrolled bleeding, nerve injury, cardiac injury, and thyroid crisis. Then the treatment options are radioactive iodine, in which it is given orally and it is taken by thyroid follicle. The advantages of the radioactive iodine is that it is no surgery is required and no prolonged treatment, but the disadvantages is that late hypothyroidism may occur. The another treatment options are anti-thyroid drugs, which are carbimazole and propylthiouracil, and propranolol is given as cardiovascular effects, and the advantages are that no surgery is required, and the disadvantages are that it is a prolonged treatment and there is a failure rate of 50%, and aplastic anemia may present, that is oropharyngeal bacterial infections. Then the another treatment option is surgery, and in surgery radioactive iodine is given orally and which is taken by thyroid follicle. Surgery in toxic and embryological subtotal or total thyroidectomy is done, and here is the problems in treatment thyrotoxicosis, that is pregnancy radioactive iodine is contraindicated. Then thyrocardic radioactive iodine plus antithyroid drugs and proptosis antithyroid drugs, and in recurrence connected antithyroid drugs radioactive iodine. So this was about the toxic multinuclear goiter or Graves' disease or hyperthyroidism. Okay, now coming towards the next topic, that is thyroid tumors. So these are the thyroid tumors: papillary carcinoma, follicular carcinoma. Then head and neck. We will study the head and neck, which is in which the important topics are acute parotiditis and pleomorphic adenoma and parotid carcinoma and carcinoma of the tongue and bronchial cyst. Okay.